Welcome to my YouTube channel. Today we are going to talk about gestational diabetes mellitus. Kindly make sure you subscribe. It will cost you absolutely nothing. So the gestational means pregnancy. Diabetes mellitus means elevated blood glucose. So this is when we have diabetes mellitus, which is first recognized in pregnancy. It was not previously there, and the definition is constant despite the fact that it may occur after pregnancy. So let's go through the notes. So it is defined as the carbohydrate intolerance of variable severity with onset, as I've said, or first recognition during pregnancy, and it's commonly present in the second or during the third trimester. Sorry, and then the definition is used, as I've said before, irrespective of the fact that the condition may persist after pregnancy or not. So other definition is when we have hyperglycemia diagnosed at first time during pregnancy. As you have said, it is common in which trimester? Second and third trimester. And also not hyperglycemia levels that do not meet WHO criterion for DM. I'm going to explain this point in the next slide. And it may occur anytime during pregnancy, and it is most likely occurring after 24 weeks. So the pathophysiology of diabetes mellitus is a result of hormonal changes that occur in all women during pregnancy. This is because during pregnancy we have increased placental hormones which interfere with the ability of insulin to manage glucose, and this is what is called insulin resistance. So in our body is like a war. So when something bad happens, it counteracts that thing that has happened. So this will result now, because we have insulin resistance caused by the pregnancy hormones, our pancreas that produces insulin will produce insulin 3 times more than the normal. So if that does not occur is when we have gestational diabetes. So usually the mother pancreas is able to produce more insulin, about 3 times the normal amount, to overcome the insulin resistance. If this does not occur, glucose will rise, resulting in gestational diabetes. Usually the blood glucose may return normal after childbirth. Sometimes they may not return normal after childbirth. So the risk factor of gestational diabetes is advanced maternal age, older mothers that is greater than 35, obesity greater than 90 kgs, previous history of diabetes, that is previous history of gestational diabetes, previous history of macrosomia, so if the mother has previous history of birthing a big baby, previous history of unexplained fetal death, that is stillbirth or perinatal loss, women with polycystic ovarian syndrome, a family history of diabetes, black list, and persistent glyceruria. This is presence of glucose in urine. So this is just addition of just what we have repeated. As I said, obesity is defined when we have a BMI of greater than 30, age, as you have said, greater than 35, previous history of gestational diabetes, persistent glycosuria, previous history of a big baby, poor obstetrics history, so we say stillbirth, perinatal loss, previous miscarriages, previous congenital anomaly, family history of glucose, especially first degree relatives, previous history of polyhydramnios. Polyhydramnios is diabetes is a risk factor of polyhydramnias, polycystic ovarian symptoms, non-impaired glucose tolerance or impaired fasting glucose, gravid multipara, so a woman who has had more than several babies, and multiple gestation, twin pregnancy, triplets, quadruplets, sextuplets. So screening of gestational diabetes. As you've mentioned before, gestational diabetes is commonly in the second and the third trimester. So if you're going to screen, you're going to screen those during that time. And you said in the previous slide, it most commonly starts after 24 weeks. So if a woman has one more than risk factor, you do random blood sugar or fasting blood sugar at first contact. Kindly note at first contact. However, for the rest of the women, screen should be done 24 to 28 weeks, as I've said, or at first contact if the woman presents late. So the test that we do, it depends on the location that you are and the guidelines that you use. However, the WHO, or what I'm going to talk about, is we have two steps. Where we have the first, where we have two procedures of screening, where you can just perform a 75 oral glucose tolerance test by administering 75 glucose orally after 8 hours of overnight fast, and do a blood glucose level 1 hour and 2 hours, and then you get the levels. Kindly note this, you're just giving one oral glucose. In the other step, it's a two-step where you start with a 50 grams and then later you give 75 grams. That is according to WHO. It's in the next slides. So as we have said before, when you are defining diabetes mellitus, we said number one, it is first recognition during pregnancy. Number two, it is most commonly in second and third trimester. Number three, it is when it is defined when does not satisfy the WHO criteria for DM. So, for example, a woman comes in. This woman has never had history of diabetes mellitus, and they came in and their blood glucose is 12 millimoles per liters fasting glucose. Then you will not categorize this patient as gestational diabetes because it will fall under diabetes in pregnancy. So let me explain. The classification of diabetes in pregnancy is divided into two: overt diabetes, that is diabetes in pregnancy, and gestational diabetes. So the gestational diabetes, when the woman comes with hyperglycemia levels of this indicated in this table, then you'll define that as gestational diabetes, and this is according to the WHO criteria. However, when the woman comes with blood glucose that exceeds the normal range of gestational diabetes, then we'll define it as diabetes in pregnancy. So in terms of fasting glucose, our definition of diabetes, gestational diabetes in pregnancy, so gestational diabetes will be 5.1 to 6.9. After I've given now our oral glucose tolerance, which will be greater than 10, after 2 hours it will be 8.5 to 11, and then a random one is not applicable. So I hope you have really noted. So in terms of screening, that's what you do. You give the 75 grams of oral glucose tolerance test by giving 75 grams of oral glucose in a patient who has fasted 8 hours, and then later record 1 hour postprandial and 2 hours postprandial, including the fasting glucose. So as I was saying before, you can employ there are two tests. There are two types of screening. The one we said one step where you just give 75%, and you can employ the two step. The two step is where you give 50 grams of oral glucose challenge without regard of time. Kindly note in the other one, you had to give the patient after they have fasted 8 hours overnight. So without regard of any time of the day or last meal between 24 hours and 28 weeks. So if it's abnormal, if the 50 grams of oral glucose challenge is abnormal, then you give 75 grams of oral glucose challenge to detect if you have gestational diabetes or not. I hope you have really understood. So depending on your context or depending on where the patient is and convenience of the patient, if this is the first time and the patient has come in and they have already taken the meal, obviously will prefer the two steps. But if you already talked to the patient and prepared them to fast for at least 8 hours, then you can do the one step. So complication. So just let me just tell you something which is kind of not included in these slides. As I've said, we have two type classification of diabetes in pregnancy. Where we have overt diabetes, this is when a patient who came in had previously, without pregnancy, they had been diagnosed of diabetes. So before even they got the conception occurred, this patient had diabetes. While gestational diabetes is when we first encounter it in pregnancy, and it must be within the levels that we have talked about. So in comparison to overt diabetes and gestational diabetes, overt diabetes occurs all through the pregnancy, including the oogenesis. So this patient will be more predisposed to diabetic embryopathy compared to our patient who has gestational diabetes. So in our terms of a complication, you won't include malformations or because gestational diabetes occurs after 24 weeks. That is the second and the third trimester after organogenesis has occurred. So we will have increased perinatal loss is associated. Fetal anomalies, however, not increased, as I've said before. This is due to absence of metabolic interference during organogenesis. You can also have macrosomia, polyhydramnios, as we already said, birth trauma, including shoulder dystocia, because if this mother has gestational diabetes, there will be an increased risk of the baby coming out to be a big baby, and that will include birth trauma in shoulder dystocia, because this fat, it's just normal physiology. Insulin, what does insulin do? It takes glucose into the cells. So if it takes glucose into the cells, which will be later converted into lipids and fats, and that will deposit in the shoulder. So the eld will come out, but will have difficulty removing the shoulder out of the mother's perineum. So recurrence of gestational diabetes in subsequent pregnancy is about 50. Remember, we said one of the risk factors is if the mother had previous gestational diabetes. So management, we have two goals of management. The first goal of management is glycemic control. The second goal of management is delivery, to ensure delivery. So in terms of glycemic control, we'll always start with diet, complex carbohydrates, calorie restriction, and among all those, in addition to exercise. So if that does not occur, or that does not achieve glycemic control, then you go to oral hypoglycemic medications or insulin. Kindly note, in terms of the gestational diabetes, our problem was insulin, because the pancreas was supposed to secrete 3 times insulin, but it did not do that. So in terms of delivery, if insulin is not required and we have good glycemic control, then you await for labor. However, if insulin is required and you have complications such as preeclampsia, macrosomia, polydramina, you consider delivering at 38-week if it had not previously brought complication that would result to earlier delivery, or elective CS or inductions. So for the management, because you can't live this life without goals and targets. So just the same as we live our lives with goals and targets, same here. You just can't manage this patient blindly. So you have to have targets. And our targets or our aims will be fasting glucose of less than 5, pre-meals of less than 6, 1 hour postprandial to be less than 7.8, and 2 hours postprandial to be less than 6.7 millimoles. So if blood is not optimized within 2 weeks, as I've said, by diet and exercise, then you put the patient on oral glycemic controls or insulin, and 15 to 30% of the patient will require insulin. In addition to that, you follow up similar as the patient's doing with diabetes in pregnancy. Delivery at 38 is advised if the sugars are well controlled, but if they are poorly controlled, then you take a specialist. Poorly controlled is where you have symptoms, things like DKA, among all other side effects. Consider steroids if you are to deliver this baby prior to 38 weeks, then you have to consider steroids. And in terms of the steroids, kindly remember, in the normal physiology, that steroids will alter the glucose control. So if steroids are administered at any point in the pregnancy, anticipate difficult glycemic control, and insulin therapy is usually advised. So in terms of the aim or the target during delivery and labor, our aim for blood glucose during delivery and labor is 4 to 7 millimoles per liter. And then in addition to that, you be ready, anticipate for maternal and fetal neonatal complication at delivery, and plan for necessary intervention. So postpartum care, after now you have delivered the baby. So you monitor the glucose. If blood glucose goes above 7.8, or fasting glucose or 6.1 millimole post delivery, then you manage as pre-existing diabetes. However, if our blood glucose is normal post delivery, then you repeat our GGT, that with the 7 grams of glucose at 6 weeks, to exclude DM or impaired glucose tolerance. If it's normal, then you encourage the patient to do a non-fasting glucose thereafter. Consider cancel on the future risk of gestational diabetes or DM. So many patients, or patients that who have gestational diabetes in this pregnancy, they have a 50% increased risk of having gestational diabetes in the next pregnancy. In addition to that, patients who have gestational diabetes in a pregnancy have to, we'll go and look at the last slide, that is the prognosis, will be predisposed to having diabetes later in the ages 5 to 20 years after follow-up. So encourage exercise, proper diet, and normal BMI, and encourage contraceptive use at 6 weeks, so that we cannot have another conception. So in terms of prognosis, nearly 50 of the women with gestational diabetes will develop overt diabetes. Overt diabetes is where you have now the 2 types of diabetes: glucose independent and glucose dependent, over a follow-up period of 5 to 20 years. Women with fasting hyperglycemia have what worse prognosis to develop type 2 diabetes and cardiovascular complication. Recurrence of subsequent, as you said before, recurrence of subsequent pregnancy having gestational diabetes is more than 50%. In addition to that, the infants born of mothers having gestational diabetes, they will have risk of overweight times 2 and have risk of metabolic syndrome times 4. Thank you.